Welcome to Gosfield and Shay on Health Law.
Hello, and welcome to Gosfield and Shay on Health Law with Alice Gosfield. Alice is a nationally recognized healthcare attorney who has spent her entire legal career advising physicians on Medicare, fraud and abuse, Stark law, and value-based payment. She is known for her strategic clarity, prolific writing, and deep influence on federal healthcare policy. I'm Heidi Mack, and today we're looking into the Stark statute, specifically the myths and misconceptions that still confuse experienced physician groups. Whether you're forming a new practice, restructuring compensation, or navigating supervision requirements, this episode will help clarify what compliance really means under Stark. This episode is Stark Law Myths Debunked: What Physician Groups Still Get Wrong. Thank you so much for joining us, Alice. We really appreciate you being here.
Thank you.
So let's get started here. Alice, you've been practicing health law since the 1970s. What first drew you into this particular area of legal work, and what has kept you doing it all these years?
I grew up as the daughter of a cardiologist, and I worked in his office from the time I was 9 years old. I was a candy striper at the hospital wearing one of those hideous uniforms when I was 13, and I went back and worked in the hospital both in college and in high school. And by the time I graduated law school, there was a really good argument that I knew way more about the practice of medicine than I did about the practice of law. One of my roommates who went to Antioch, which was a work-study school, had gone back to look for a summer job and found this thing called the Health Law Project. And she came back and said, "I found the perfect job for you. It's in Philadelphia." I said, "What is it?" She said, "It's the Health Law Project." I said, "There's no such thing as health law." She said, "I know." I said, "It sounds perfect." And so I ended up working there. It was at the inception of health law, and it was a war on poverty program, and that's what started me out.
Wow, that's incredible. Well, I love hearing your story. So, but we'll move on to why we're here. For those unfamiliar or newer to compliance, what is the Stark statute designed to regulate, and which providers does it apply to?
Let me start off by saying it is the single worst piece of legislation I've had anything to do with in my entire career, which is not just a few weeks old. My standard line is the people who wrote it were not unduly burdened by any knowledge of the way Medicare actually works. It was a utilization control regulatory mechanism, the idea being that it would blunt the motivation of physicians to refer patients for specified services under Medicare and Medicaid when they had a financial relationship with the entity that they were referring to. It's relevant to physicians only. Many people are confused by that. Even if you have nurse practitioners or physician assistants who are doing exactly the same thing as physicians, they are not affected by this. But the definition of physicians in Medicare is not just MDs and DOs. It's also dentists, podiatrists, chiropractors for only one service. So it's a little broader than MDs and DOs, but it's only physicians.
The term fair market value and commercial reasonableness often get grouped together. How are they different, and why does that difference matter for Stark compliance?
So the Stark statute runs in tandem with the anti-kickback statute, which is far broader and is relevant to all federal healthcare programs. Both of them rely heavily on the definition of fair market value, which is a judgment that is made with reference to general market value in the community. I read tons of contracts that other lawyers write that say the parties agree that the compensation set forth in this agreement is fair market value. That's meaningless because what you agree is not the standard. Commercial reasonableness is only in the Stark statute. And I want to read what the definition is because it really is a sort of the notion that the transaction makes good business sense for the parties, not with reference to external value. Commercial reasonableness means that the particular arrangement furthers a legitimate business purpose of the parties to the arrangement and is sensible considering the characteristics of the parties, including their size, type, scope, and specialty. An arrangement, and this is significant, may be commercially reasonable even if it does not result in profit for one or more of the parties. So it's very different from fair market value, even though it sounds like it's the same thing.
Well, then, when we talk about Stark compliance, a key term is designated health services. What exactly falls into that category, and does that include things like a group using its own DME number?
So there is a hit list of designated health services. It's not everything that can be provided in Medicare. And by the way, the statute is a Medicare only with some implications for Medicaid statute. It doesn't affect any other kinds of programs. So the list of designated health services is clinical laboratory services, physical therapy, occupational therapy, and outpatient speech language pathology services, radiology and certain other imaging services, almost all imaging services, radiation therapy and supplies, durable medical equipment and supplies, parenteral and enteral nutrients, equipment and supplies, prosthetics, orthotics, and prosthetic devices and supplies, home health services, outpatient prescription drugs, and inpatient and outpatient hospital services. So it's a big list, but it's a specified list, and there are things that don't count. As an example, electrocardiograms are diagnostic services that are not Stark, but an X-ray is. And so the government publishes every year the list of the CPT codes. Those are the procedure and terminology codes that determine what the designated health services are, because under each of those statutory categories, there are reams of different CPT codes that are relevant. A group practice actually can only use their own durable medical equipment number as a supplier to provide crutches, canes, and walkers that the patient uses to ambulate from the office, not wheelchairs, not beds, not all other kinds of durable medical equipment, primarily because one of the exceptions that allows physicians to refer within their groups for designated health services is what's called the in-office ancillary services exception. And durable medical equipment that's not used to ambulate from the office isn't used in the office. And so to send it to a patient's home, a big bed or a commode or something like that can't meet the standard. And even lawyers get that wrong.
Independent contractors are often used in physician practices. Can they be paid productivity or profit sharing compensation under Stark? And if so, what limits apply?
So they can be paid productivity, which is giving them a portion of what it is that they generate themselves. They can be included in profit sharing, although they don't have to be included in profit sharing. But there are rules that pertain to how profit sharing can be done, and independent contractors can be included along with members of the group, which is just partners, shareholders, and W-2 employees.
There's a persistent belief that hospitals can't pay physicians for quality performance unless it is in a value-based arrangement. What does the law actually allow then?
So the value-based arrangement concept didn't even emerge until 2020. In 2007, when the Stark regulations were published, the regulators explicitly said hospitals can pay physicians for outcomes, quality-based determinations, patient satisfaction. Most people don't know it because it's not in the regulation itself, it's in the preface to the regulation when they describe what the meaning of the statute is. So that's particularly useful in co-management agreements, which we'll talk about it in another podcast.
So then some assume that billing under a single tax ID or Medicare number automatically qualifies a group as Stark compliant. Why isn't that enough?
When the Stark statute was enacted, it was during the heyday of what was then referred to as group practices without walls. And the guy who was primarily the driver behind Stark introducing this legislation was an MD-JD named Steve Bandian, who thought that the anti-kickback statute with its criminal penalties and intent-based liability wasn't strong enough to prevent this perverse incentive of physicians referring to the entities with which they had financial relationships. So they wanted to not thwart the ability of true group practices to be able to have these ancillary services that are designated health services go on within their groups. So they said it had to be centrally controlled, it had to operate as a unified business, it had to have at least two members, which is the shareholder, W-2 employee, or partner. 75% of the encounters of the group have to be conducted by members. When you average the time that the members, not the independent contractors, that the members spend with the group, it has to come to an average of more than 75%. So you can have one guy that spends 100% of his time with the group and another guy who spends 20% of his time with the group, and you're still okay because that's higher than 75%. So those were the indicia they thought would mean that the people who would be eligible to make money from these ancillary services would in fact be true group practices.
So then the definition of a group practice under Stark includes very specific requirements, like how income is shared, how supervision is structured, and how a physician's time is allocated. Which of those areas tend to cause the most unintentional mistakes?
I think compensation and profit sharing, in part because some of the rules have changed over time. One of the things that happened in 2007 was out of the clear blue sky, after 30 years of the history of the Medicare program, they suddenly decided that diagnostic testing could not be provided incident to, and we'll get to that in a second. But it meant that the technical component for diagnostic testing couldn't be allocated dollar for dollar to the physician who had ordered the service. And there are settlements, the very first settlement that had to do with having failed this diagnostic testing standard took place 22 years after the law was first enacted. And it happened that it was the allocation of the technical component of CT scans in a cardiology practice. And they had to pay, north of $1 million worth of settlement of false claims liability for the claims that had been submitted. By contrast, and even lawyers don't get this right, you can allocate services that meet the definition of incident to services dollar for dollar directly to the treating physician. And for lawyers who are not really steeped in this, that sounds like it's a payment for referrals, because incident to services by definition are done by somebody other than the physician. But it's a specific category that the statutory language made available, it's good. It provides for some flexibility for what's otherwise a strict liability law.
The rules around incident to billing can be especially confusing in the Stark context. What should practices know about supervision, scope, and how those revenues are handled? And how does the anti markup rule fit in here?
So incident to is an almost archaeological concept in the Medicare program. It was enacted into the statute when it was first adopted in 1966. And the theory of it was, if you thought about what a physician practice looked like in those days, it was usually one or two docs who were on their own, and they were supported by some personnel, a medical assistant, and a very fancy practice, a nurse, and very often it was the physician's wife that managed everything in the practice. And they took vital signs, and they drew blood, and they gave injections, and they did EKGs. And if Congress had said, we're only going to pay for those hands-on services that are face-to-face done by the physician, nobody would have participated because their practices couldn't function that way. So they said, we're going to pay for physician services and those services that are an incidental, although integral part of the physician's personal professional service to the patient. So first there has to be a physician service to which the ancillary services are incidental. Then there has to be a physician on premises who's part of the group, on premises and immediately available to assist during the time the services are being provided. When you submit the claim, they changed the rules in the 2000s. So in a way that I find completely illogical, the name of the physician that goes on the claim form for incident to services is the supervising physician, who may never see the patient, may never know the patient, may not even know that they're being billed incident to, and don't have to know that they're being billed incident to, instead of billing it under the treating physician. And still those incident to dollars can be allocated to the treating physician, whose name may not be on the claim form. Anti-markup is totally different. Anti-markup is solely about diagnostic testing. And it basically says, what are the circumstances under which a billing and ordering physician can mark up a service that he buys from another physician? And the standard that the government came up with, also crazy as far as I'm concerned, is that a billing and ordering physician can mark up the services, diagnostic services only, that he buys from an external physician if he shares a practice with the physician who's supervising the technical component or is performing the professional component. And sharing a practice can go on in one of two ways. You can either spend 75% of your time with the group that's billing, or you can be on the premises of the billing and ordering physician, and then he can mark up what he buys from you. So anti-markup is about how much the physician can charge for a service that he personally did not render. Incident 2 is about incorporating services that are closely related to what the physician is doing in the physician's compensation.
Well, then, compensation models often do raise red flags. What are the acceptable ways to structure productivity bonuses or profit sharing arrangements without triggering stark violations? And do personal service arrangements really have to spell out aggregate compensation in advance?
So the concept of paying physicians productivity is a very common approach in physician practice. So under Stark, physicians can be paid for what they do personally themselves and what are services that are incident to their services. They can get dollar for dollar credit. They can get 50% of what it is they generate. There's no standard with regard to how that goes. Profit sharing is totally different. That's where the profits from designated health services may not be allocated to the ordering physician. They have to float up into one pool, and this is a change in the law, one pool for all of the designated health services profits, but then you can divide those profits up differentially among the physicians in the group as long as each pot is at least 5 physicians. So you can have some guys who get paid on the volume of their work RVUs. You can get another pot of people who get paid on seniority. You can get another pot of people who get paid on how many patients they have on their panel. So there are a range of metrics that you can use to allocate the profits, but it's one pool of money for all the designated health service profits that are going to be shared.
Alice, thank you so much. I never knew that health law was so fast. And you've been there since the beginning. So I'm telling, if you need help with this, you need to come to you. You know what you're talking about. So for everyone out there, thank you so much for listening to today's episode of Gosfield and Shay on health law. If your organization needs guidance on Stark compliance or group structuring, visit gosfield.com. Be sure to like, subscribe, and leave a review if today's episode was helpful for you. And thank you so much for joining us, Alice. We really, really appreciate it.
Thank you, Heidi.
Thanks for watching. Be sure to hit that like and subscribe button and leave us a review in the comments.